Welcome back to Gyno Files. Intrauterine fetal growth restriction, also called IUGR or just FGR, is when a fetus in utero has an estimated fetal weight less than the 10th percentile or the abdominal circumference is less than the 10th percentile for its gestational age. The etiology of IUGR can be viewed as either maternal, fetal, or placental. Ultimately, there's a suboptimal perfusion between the uterus and the placenta. So what are some risk factors or causes that we can see that lead to IUGR? Maternal etiologies can be things like a chronic disorder associated with vascular disease. Things like chronic hypertension or high blood pressure, diabetes, antiphospholipid syndrome, substance abuse, things like alcohol, cocaine, smoking, narcotic use. Maternal malnutrition, or the mother's eating at a caloric deficit. Things like teratogens or exposure to medications that can lead to IUGR. Infections like malaria, CMV, syphilis, toxoplasmosis. Fetal etiologies, we can see things like chromosomal abnormalities. Placental etiologies, it can also be things with the umbilical cord, developmentous cord insertion, or a marginal cord insertion. Why do we worry about babies that are IUGR? The growth restriction can increase the risk of stillbirth and also lead to neonatal morbidities and mortality. How do we screen for IUGR? Starting at 24 weeks, we start to measure fundal height. This is where we take out that measuring tape and we measure from your pelvic bone to the top of the uterus or the fundus. With the fundal height measurement, it should lead up to the week gestation that you're currently at. If it's off, then we can follow up with an ultrasound. In order to get a growth on the baby, we're going to measure the biparietal diameter, the head circumference, the abdominal circumference, and the femur length. Make sure that you're looking at the placenta, you're looking at the amniotic fluid. You're also looking at the anatomy of the baby. To get a better idea of how that baby is doing, you also want to look at the umbilical artery Dopplers, how the blood flows through the umbilical cord. If you had IUGR in one pregnancy, the risk of recurrence in the subsequent pregnancy is about 20%. How do we evaluate and manage once we've made the diagnosis of IUGR? Ultrasound remains the best method for evaluation. So you can expect serial growth ultrasounds about every 3 to 4 weeks. Does anyone know why we don't do the growth ultrasounds more frequently? If you do, let me know in the comments. For evaluation, we start doing a biophysical profile or BPPs at 32 weeks and check the umbilical artery Dopplers as well. When do we recommend delivery for IUGR? This is going to vary case by case. If you're strictly an isolated IUGR, meaning there's nothing else going on in the pregnancy, usually we recommend delivery between 38 and 39 weeks. You have IUGR plus other risk factors, it can be as early as 34 weeks, or we may be able to push it to 37 weeks. These are things that you're going to discuss with your doctor. I hope you learned something new today, and I'll see you in my next video. Bye!